Great. Hello and welcome, everyone. Thank you for joining us today. We are very excited to have you all here for our Women in Global Health quarterly gathering today. We are going to just wait a few minutes to give others time to sign in and join us. But in the meantime, we again want to thank you for joining us so far. And if you would like in the chat, just a round of introductions, and maybe you can say your name, your organizations, and maybe mention something that you want to show gratitude towards today, no matter how big or small. Our special event today will touch on the most recent policy change on Roe v. Wade and Plan C, which is a public health initiative that is transforming access to abortion in the United States. But again, we'll wait a few more minutes and give everyone a chance to join us. Thanks so much for putting your name and organization in the chat to let us know what you want to show gratitude towards today, and we can continue with our session. So just reiterate for everyone who just joined us, our special event today is going to touch on the most recent policy changes due to Roe v. Wade and Plan C, which is a public health initiative that is transforming access to abortion in the United States. My name is Claire Guaychore. I'm one of the outgoing co-chairs of Women in Global Health Seattle, and we are very honored that you chose to be with us this afternoon or this evening, depending on where you are in the world. Before we begin our program, let's take a moment to ground ourselves and to respectfully acknowledge the land where we are today. If you are joining us from the Seattle area, we acknowledge that we're on the unceded territories of the Coast Salish people, including the Duwamish past and present. If you are joining us from elsewhere in the United States, we invite you to learn more about the tribal land you occupy by visiting the link in the chat and to truly commit through words and actions to demonstrate respect, support, and rights to the true owners of these lands. The main portion of our event today will center around our discussion around abortion rights and Plan C. Before we jump into that, we're going to introduce our new chapter co-chairs and new advisory board members. As I mentioned earlier, I'm one of the outgoing co-chairs along with Linda Oseso, and we are very excited to formally announce our new co-chairs for the coming year, Fatima Al-Shamari and Haley Bridget. I'll say a few words about this change. For me, I can say that it has truly been a pleasure to serve as an advisory board member and a co-chair of this amazing organization for the last few years. And I find myself extremely grateful to have had the opportunity to serve alongside such amazing women who are now part of the advisory board, and also those of you who are members. We are all difference makers in our own right, and I really have just had a great experience working with so many of you. And I'm fully confident that under Fatima's and Haley's leadership, WGH will continue to thrive and make tremendous impact within our. I would now like to welcome Fatima and Haley to say a few words and to introduce the new advisors joining the WGH Seattle Advisory Panel this year. Over to you, Haley and Fatima.
Thank you so much, Claire, for that lovely introduction. We're going to miss you greatly and want to thank you for your instrumental contribution to the chapter. Hello, everyone. My name is Fatima, and I'm very honored to serve as the new chair of the Women in Global Health Seattle Chapter. I first joined WGH last year as an advisor after nomination from my mentors, Drs. Ala and Claire, and I quickly felt the sense of community that the panel created between new and past members and the inherent empowerment from connecting and working with successful women in the community. As chair, I'm really looking forward to working with Haley, Kayla, Jasmine, and the amazing advisors to bring to you all another exciting year of excellent global health advocacy. On to you, Haley.
Thanks so much, Fatima. Hi, everyone. I'm Haley Pritchett, and like Fatima, I joined the advisory panel last year. So after a year as an advisor, I moved into what is now turning into a vice chair role, and I'm so looking forward to supporting Fatima as we move into new structure within our WGH Seattle group. The regional chapters of WGH are just growing exponentially around the world, and we have a lot of new changes and structure that we're moving into this year that we're really looking forward to, including some new events and structure with our Seattle chapter, but also with our new Northern American hub. So we're starting to work with regional chapters throughout the nation to create some events for you all. And I'm really looking forward to working with you all and learning from you. Thank you.
Awesome. Can we please have the next slide? Thank you. And so before I introduce the amazing advisory panel, I'll just give a quick overview of how the advisory panelists were selected. So thanks to you all for nominating advisors to our Women in Global Health Advisory Panel. We first opened up nominations for the advisory panel on July 8th of last year with the deadline of August 10th. And all nominations came through and were submitted to our existing advisors at the time for review. At our last Women in Global Health Advisory Panel meeting, we then reviewed the nominees as a panel, and we voted on the new advisors based on the diversity of their identities, their lived experiences, career stages, and the disciplines that they had. And in this slide, you'll see the returning, may we have the next slide, please? Thank you. The returning advisors. And the next slide, please, we'll have the new advisors who will be joining us today. And so they'll be introducing themselves today. We can start with, so our new advisors are Alicia, April, Patience, Tina, Dorothy, Shaun, and Kiara. We're very honored to have these 7 exceptional women join our panel. We've invited the new advisors today to take 1 minute to introduce themselves, giving their name, what they're looking forward to as advisors, their job roles, and their organizations. So may we start with Alicia, please?
Thanks, Fatima. Hello, everyone. My name's Alicia Anamale. It's such an honor to be serving on the WGH Advisory Panel and to be a part of this wider Washington Global Health Alliance community. I'm really looking forward to supporting and learning from my fellow advisors as we work to advance gender equity in global health. And I serve as the Director of Programs at the Max Foundation, a global health organization headquartered in Seattle that works to provide medicines, diagnostics, and support to cancer patients in low and middle income countries. Thank you.
Thank you, Alicia. May we please have April next?
Hi, I'm April Haberman, and I have been in the global health space for nearly 10 years now, and I'm thrilled to be a part of the WGH advisory panel for the next few years. I'm excited about a lot of things, but I am mostly looking forward to meeting other passionate, dynamic women that I can collaborate with and bring about long-lasting change for other women. I truly consider it an honor and privilege to have the opportunity to bring my skill set, experience, and network to the table. I currently work with Days for Girls International as their Senior Development Director. Thank you for having me.
Thank you, April. And may we please have Patience next?
Hi, my name is Patience, and I'm the second year MPH student with the Department of Global Health, University of Washington. So professionally, my vision is to be a leader who empowers girls and women to reach their goals. And this is usually girls from marginalized communities, to break like limitations placed on them by culture and society. And so for me, being part of the advisory board, I look forward to building myself professionally and also to contribute to the organization's goal. So that's what I look for. Thank you.
Thank you, Patience. May we please have Dorothy next?
Hi, good afternoon. My name is Dorothy Miller, and I am so excited to be in this role and to get to work with all the amazingly talented folks on the line, as well as other folks in the community. And I've worked in the past with WGH and in the scope of small groups, but I feel like this is a really different way to connect and just support the incredible work going on. I'm currently a director of global public policy with Merck Vaccines. And I've been in that role for about 5 years. So wonderful to be connected with all of you.
Thank you, Dorothy. And Shaun, please.
Hi, everyone. My name is Rifat Ara Shaun. I go by Shaun and use she, her pronouns. I'm really looking forward to learning that how serving in this advisory role in a platform like WGH shapes my experience as a woman in global health. And also, I look forward to contribute by bringing in the experience of my own, and also by with a reflection of many other women who work hands-on in public health research and practice in low research settings like Bangladesh. So I'm really looking forward to it and very grateful to be in this space. My current organization is University of Washington. I'm a PhD student in epidemiology there. I'm also affiliated with a Center for Injury Prevention and Research Bangladesh, where I've worked for a couple of years now. Thank you so much.
Thank you, Shaun.
Okay, can you hear me? Okay.
Yeah.
All right, thank you, Fatima, and thank you so much to our new advisors. We're very excited to have you on the panel, and thank you for your introductions. So wonderful to hear from you all. My name is Solmaz Chakrabarti, and I am one of the second-year advisors on our Women in Global Health Seattle Advisory Panel. It is my honor and pleasure and privilege to introduce our special guests for today's session on Plan C. Not only because I respect and admire both of these women who are doing important work in the US and the world, but also because abortion access is the reason I pursued a degree and career and a career in public health. I will say that I feel as strongly today, if not more so, as I did when I worked as an abortion counselor in Utah a couple of decades ago, that abortion is a human right and an essential health option. And I'm proud to say that Women in Global Health in Seattle stand firm on the same belief. For those of you who may not have yet seen this, Women in Global Health Global Chapter have issued a statement about the unconstitutional overturn of Roe versus Wade in 2022. And the link, I believe, is in the chat box. Now, without further ado, please allow me to introduce our guest of honor, Elisa Wells, who we're very excited to have here as a speaker today. Elisa is a public health specialist with 30 years of experience in the reproductive health movement, with expertise in the evaluation, training, and strategic program management of family planning and reproductive health programs, both in the United States and abroad. She specializes in emerging technologies and innovative approaches to reproductive health care, including emergency contraception and medication abortion. She spent her early career at PATH and has since consulted for a wide variety of organizations, including the MacArthur Foundation, Planned Parenthood, Reproductive Health Technologies Project, the Association of Reproductive Health Professionals, and more. In 2015, she co-founded Plan C, a groundbreaking campaign that shines a light on the over-medicalization and over-regulation of abortion pills and advocates for safe, effective, self-managed option in the US to counter the politics and stigma that have crippled access. Since then, Plan C has grown to become a leader in the movement for reproductive rights and abortion access, and Elisa has become a voice in press and media willing to challenge the status quo and put forth a vision for a new reality, a world with democratized access to these safe, effective pills as self-managed care option. From her first job as an abortion counselor in Boston to her years of work abroad in countries with fewer resources and rights, Elisa brings practical solutions, passion, and action to the fight to improve abortion access in the United States. Joining Elisa today is my friend and colleague and mentor, Amie Bishop. Amie Bishop is the Director of Humanitarian and Global Development Program at Outright International, which is a global LGBTI human rights organization. She is a human rights advocate and global health leader and professional with professional experience in more than 20 countries. Since the start of Russia's war in Ukraine, she has been managing Outright's Ukraine Emergency Fund, as well as a new program to advocate for better inclusion of marginalized populations in health and humanitarian action during the crisis. From 1989 to 2014, she worked at PATH, where her work spanned a variety of leadership and technical roles in the areas of TB, HIV, women's cancers, and reproductive health. Amie is an adjunct clinical instructor at the University of Washington's Department of Global Health and recently completed a 3-year term on the advisory panel for the Seattle Chapter of Women in Global Health. Amie holds master's degrees in social work and public health from Columbia University. Without further delaying this, over to you, Amie and Elisa, and thank you.
Thank you so much, Solmaz. That was a wonderful introduction. Excuse me. Hi, Elisa.
Hi, Amie.
I'm so excited. We were paired together for this. I mean, obviously, Elisa, you'll soon know what an incredible resource and expert she is on this topic of abortion rights and medication abortion. But I just have to say briefly that she and I started literally within weeks of each other at PATH in 1989. And so we have been professional colleagues and dear friends for more than 30 years now. And so it is an enormous pleasure for me to be able to moderate this discussion, this fireside chat without the fire, but hopefully a lot of warmth in any case. So I want to just jump right in quickly because this is such an important topic. It always has been. It's just that it feels even more sort of at a crisis point at this juncture. So we know very well that even with the Dobbs decision, even before the Dobbs decision, safe and legal abortion was already inaccessible in many states. But with Dobbs, those sort of pre-existing inequities have been magnified, and now, of course, new restrictions are in place. And I'm just going to cite a couple of recent stats to give us a little bit of a foundation for the discussion, and then we'll turn to Elisa. But recent studies just a couple of months ago or less in the Journal of the American Medical Association on the impact of Dobbs in the US suggest that Dobbs significantly changed the way already how people are accessing abortion care in the US in terms of where they go, how they get abortions, what barriers they face. So for example, 2 months post Dobbs, there was a 6% decrease in clinical abortions overall, but a 95% decrease in the states that banned or severely restricted abortion. This, however, is really important to note, and we'll get into this in the discussion, that this doesn't include self-managed abortion. The data also suggest increases in clinical abortions in other states. So for example, a 37% increase in North Carolina because of its proximity to states with increased restrictions, although we certainly got some good news out of South Carolina recently. Closer to home, at Planned Parenthood's clinic in Pullman, Washington, about 78% of patients in July alone came from Idaho. And also travel times to abortion facilities increased about 3 times on average, but the largest increases were seen in the South and among poorest populations who are experiencing the largest absolute increase in travel time. So the situation feels even more dire than it did before, and it felt pretty dire even before. Although, of course, the recent elections in November were somewhat encouraging, with 4 states now having constitutional protections for abortion. And I think about 17 states and Washington, D.C. having protective laws. And then just a couple of weeks ago, which I hope, Elisa, you'll be able to shed some light on, the U.S. Food and Drug Administration's ruled that abortion pills can now be offered through retail pharmacies with a prescription. So I hope you can help clarify a little bit what that means. But I think the focus of this discussion is that clinical abortion is not the only option, thankfully. And as we're going to hear from Elisa, tens of thousands of people each year are accessing self-managed abortion, also called medication abortion, through an incredibly robust alternate supply system involving peer-to-peer networks, generic products from India, for example, and a lot of learning from around the world where people have been sharing information about safe managed abortion for really decades, right? So I want to just jump right in. Finally, we get to hear Elisa's voice. But I really want to just start with the basics. If you can just tell us, what are abortion pills, so to speak, and what is Plan C?
Yeah, well, first, I just want to say thanks for the invitation to speak with all of you. And it is so much fun to see all of the familiar faces and names from my time at PATH way back when. So I'm just really appreciative of this group and of the opportunity to do this with you, Amie. But let's start with, the basics. What are abortion pills? There's 2 types of medication that are used for abortion, typically mifepristone and misoprostol. You might know mifepristone as RU46 or Mifegest or Mifeprex. They can be used together sequentially over the course of a couple days to induce an early abortion, or misoprostol can also be used alone. Either way, they're very safe, very effective. They're approved for use in the United States up to 10 weeks from the last menstrual period, but commonly used by clinicians off-label later, commonly up to 11 weeks. And now we're starting to see clinicians using them up to 12 and 13 weeks. And we also know that the research from on later use, even into the second trimester, shows safety and effectiveness of various regimens. So the thing that is so exciting about abortion pills is that they are able to be used by the person who needs the abortion themselves, right? So it's not a procedural type of thing, and you don't need to have somebody who has that clinical training in order to have an abortion. You can take the pills into your hands and put them in your mouth and have your abortion. And in fact, the World Health Organization has said that self-managed abortion is safe up to 12 weeks from the first day of your last menstrual period, as long as you have a correct, with pills I'm talking about, and as long as you have the correct instructions and you have access to emergency care in the rare event that you might need it within about, an hour's travel time from you. So the second part of your question is, what is Plan C? Plan C is an initiative to really shine a light on this technology of abortion pills and the potential that we believe they have to transform access to abortion in the United States. We do research, we share information, and we have been doing a lot to help catalyze new routes of access to these pills in the United States.
That's amazing. That's amazing. I'm thinking back because, back when we were both at PATH together, one of the things that you worked on was actually Plan B, which was emergency contraception. And you were really involved along with a number of colleagues from PATH at the time, and also at the University of Washington, I think, to make Plan B available without a prescription in Washington State, and then also around the world, I think. So I'm curious to hear how that experience pushing for better Plan B access possibly influenced the approaches that you're now using to promote Plan C.
Yeah, what a great question. there are so many parallels between the two technologies. And in fact, so many that we were commissioned to write a white paper about it by the Reproductive Health Technologies Project back in 2015. The products themselves have a lot of similarities. You know, both emergency contraception and abortion pills were relatively unknown. You know, the use of abortion pills in the United States has only recently gotten above 50% of all abortions. And that's different in some places, like in Europe, they're much more better known than they are here. Both of the products are highly stigmatized. Both require timely access. Emergency contraception, obviously faster than abortion pill access, but both have timelines associated with use of the product. They're both very safe. They're both over-medicalized, I would say, and they have medical gatekeepers, people who write prescriptions for them or otherwise, you know, are a barrier to access in some way. Both are probably not considered ideal by the medical community. Emergency contraception was considered less effective than regular use of contraception, so it was hard to get medical community to see that it did have a role in the spectrum of offerings. And surprisingly, a lot of the medical community doesn't really like medication abortion, and there's been a little bit of bias against it over the years, until now, where I think people are starting to see more of the potential and to figure out that the person who's using them actually, you know, it can be a preferred method. And then with respect to product, you know, there was no dedicated product for emergency contraception and also a highly regulated product for mifepristone. So, you know, there's so many similarities, and also with respect to how we go about changing access, we've used a lot of the lessons learned from that experience with emergency contraception to promote better awareness and access to medication abortion.
Mm-hmm. That's great. And both, of course, have been targeted historically by anti-abortion movements, and yet there's been this recent statement now put out that emergency contraception Plan B is actually not an abortifacient, to really make that crystal clear, if I understood that correctly. So that's important. There's so many things in what you just said that I want to pick up on, one of which being why medical providers themselves are a bit reluctant. But before we go there, because, you know, the audience here and your background actually really ties into global health, I'm wondering if you could speak to how innovations that occurred outside of the US, especially regarding self-care, influence this work as well?
Yeah, it's a lot of people always ask us, well, how did we come up with this idea for Plan C? Yeah. But it was really, the innovation was created by women in Brazil in the 1980s who figured out that they could use misoprostol to induce early abortion, you know, when it was illegal and people were dying from having unsafe abortion. And then it spread by word of mouth through Latin America and then the world. And, you know, it's such a powerful story that it was the people who needed the abortions themselves who took it into their own hands and shared the information with others as a way of getting around these really unjust bans. And, you know, it ended up having positive health impact for them because at least it would start the process of having a miscarriage, and then they could present at hospitals and get miscarriage treatment, whereas they couldn't present at a hospital to get abortion treatment. So, you know, that, as you mentioned earlier, was happening for decades and among feminist networks, and these pills were being socially marketed by DKT and PSI and others. So there was this really robust example of how abortion pills and the technology could be used. And Francine Coiteau, who's another of the Plan C co-founders, and I we're actually doing an evaluation for MacArthur Foundation in Ethiopia. We're standing on the streets of Ethiopia. We sent our local colleague into a pharmacy and we said, can you try and buy abortion pills? And about 10 minutes later, she came out and she had spent about $6 or $7 and had abortion pills, a packet of them that was 1 mifepristone and 4 misoprostol that was, in her hands. And, just the disconnect of being in a country that has such, health infrastructure challenges, and yet they had access to this, potentially life-saving treatment, medication. We thought, now, why is it that we don't have this in the United States? And what could we do to try and get to a point where we have these pills more directly in our hands in the United States? So that was sort of the genesis, but we can't take credit for this idea. This is an idea that came from people around the world spreading the knowledge to each other.
That's so interesting. Yeah, I remember very well the Brazil when that was really becoming more understood, so that this is what was happening. But on this point of regulation, I guess, because you already have mentioned a couple of times about the overregulation, and I'm wondering, if you can sort of describe the trajectory of the pills as they currently are from when they were first developed and then regulated and talking about in the US context right now. Why are they so overregulated? What are the issues there?
Right. And, I just want to go back to the mifepristone pill was developed in France, and the first place it was approved was in France in 1988. And then soon after, many European countries followed in the early 90s approving it. But part of the story is the delay. Why was it not until the year 2000 in the United States that the FDA approved it, right? So we have about a 10, 12-year delay. And, the only explanation, or the one that I believe, is politics. It was a very political process. The data were there, and even when it was approved in 2000, there were all these restrictions that were attached to it. So this medication, mifepristone, not the misoprostol, because that had already been approved for other uses. But mifepristone is under what's called a risk evaluation mitigation strategy, or REMS, you might have seen in the press. And so there are all sorts of requirements that were attached to it that aren't attached to other drugs, like the people who prescribe it have to be specially certified with the distributors. And then they had to order it themselves and dispense it themselves. So for a long time, they couldn't dispense it. It couldn't be dispensed through a pharmacy. That was the recent FDA determination that Amie mentioned earlier, right, is that now they can be dispensed through a pharmacy, but not like every other drug. Every other drug, pharmacies can just purchase them and dispense them. This, for mifepristone, they added a new requirement. Even though they took away one requirement, they added a new one, that pharmacies need to be specially certified now. And they didn't even have a way of doing that. So they're having to set up a process. So, when we say they're overregulated, these drugs are safe, they're effective, safer than Tylenol, and yet they have all of these special requirements attached to them. Why is that? I mean, it really is politics that's, gumming up the works, creating obstacles and barriers. There have been so many attempts to remove these over the years that have been unsuccessful, despite the American College of Obstetricians and Gynecologists saying that they, create barriers to access to care and are not unnecessary. I mean, all of the science points to the need to have these pills available in the same way that every other medication is available, and yet the FDA still hasn't done it. So, a couple of weeks ago, when this new announcement came out and everyone was all excited, oh my goodness, we can have these pills in pharmacies. Those of us who've been working on this issue for years or decades, we're not all that excited. Yes, it needs to happen, but it was not all that groundbreaking.
Well, that's a bit of a sobering reality check then, but thank you for clarifying that, because that's frustrating to hear. I'm thinking that maybe for people to really get an idea of sort of what a woman's or experience might be in accessing these pills, can you let's say you are someone who lives in a heavily restricted state like Texas or Mississippi. Can we get a real sense of what a demedicalized, self-managed approach to care looks like? So, how does the person first go about seeking Plan C? How do they start the process? What does it cost? Those kinds of things. Maybe just as someone seeking Plan C, what would be the process?
Right. And I want to clarify that Plan C is not an actual pill, right?
Sorry, sure.
It's an idea.
Yes,
It's an idea that you should be able to have abortion pills in your hands so that when your period's late, there's something you can do. You can take a pill to bring your period back.
For that correction.
Yeah. Well, I mean, as I think most people recognize, we just live in such a divided country with respect to access. And, if you look at Washington State, great access. We have telehealth providers, all sorts of things, but it's really, really bleak in some places where there are, total bans like Texas, or 6-week bans, because most people don't even know they're pregnant by the time they're 6 weeks from the last menstrual period. So, but I guess the good news is that there are ways that you can still access pills if you live in one of these restricted states. We know that abortion pills by mail are available in all 50 states, and that's part of what we do at Plan C is we research those routes of access and we help people understand what they are. But if you were living in Texas or Mississippi, access might look like traveling to another state. We know people are doing that, and that there are great resources available to people through the abortion funds and also through practical support networks that can help help somebody make an appointment and understand how to do the transportation and provide practical support as they are doing that. But that's not for everybody. It's not a practical solution. The logistics of taking time off from work, finding childcare, arranging for and paying for transportation. I mean, they just might not be feasible for a lot of people, or people might not want to do that because it's, a huge rigmarole just to get your hands on some pills, right? So we do know that a lot of people are accessing pills by mail through multiple routes. And some of those ways are through Aid Access. You may have heard of Rebecca Gompert's group, operated out of Amsterdam. It's a human rights-based organization. They provide a medical consultation. It's an online form, so it's not a video visit. And then they write a prescription. They send the prescription to an Indian pharmacy, and that they send a generic pill to the person in wherever they are. In restricted states, it can take up to 3 weeks to get the pill. So of course, the pregnancy is progressing as you're waiting. It's not ideal, that timing. We're working on ways that might get sped up. It's $150 or less. They will discount down to $0 if the patient says they can't pay. So that's one way. We know that people are using mail forwarding services.
Mm-hmm.
So you can rent a virtual mailbox in a state that allows telehealth, like California. And then you can go to Aid Access in California, which is actually served by a US-based provider who's licensed in California, has their own medical practice in California. You can do your online consultation. Again, no video visit. The cost is $150 because the product cost is higher in the United States. But again, they'll discount the price down to $0. Costs about $50 to rent that mailbox, though. So that's something that we haven't figured out how to reimburse people for yet. And then when the product gets shipped to the California mailbox, you can forward it to yourself wherever you're sitting. So a lot of people are doing that.
Wow.
There are also these community networks that are, they're feminist groups that are getting access to pills through amazing ways. And they send them to people who request them for free. So 2 of those are Red State Access and Las Libres out of Mexico.
Amazing.
And we know that Las Libres served 10,000 people just in the 6 months after Dobbs, 10,000 doses of these medications in the United States. It's really mind-blowing.
That's incredible. You know, I just, let me just interject quickly, because I'm not going to do all the questions as they come, but there is a question Fatima asks if physicians need to have a special license to prescribe abortion pills.
No, you don't need to have a special license to provide abortion pills. You do need to register with the provider, and now with pharmacies, there's a way that they have to register in order to be able to have their prescriptions filled. But there's no special training. And in fact, we had always hoped that primary care providers would take this on as a service that they could offer to their patients. And more of that is happening. In fact, one of the great telehealth services in Washington State is run out of a direct primary care office. So no special licensing or anything like that
needed. Yeah, great.
Yeah. And I did want to mention one other route of access for people living in Texas or wherever are these unregulated pharmacies that are out there. We get emails practically a couple every week saying, oh, we're a new pharmacy that's set up to provide pills, and we ship to every state in the United States. So we're busy testing those. The ones that we've tested have all provided medication. It's been real medication, generic pills from India. And sometimes as quickly as 4 or 5 days they arrive, and that the pricing on that is about $195 and up. It can get quite expensive to use those pharmacies, but you know, if you're in a pinch and you want them fast, you can get pills that way.
Well, that actually leads to my next question, which is about sort of issues of legality, because you know, you hear unregulated pharmacy and sort of think, well, that generally my response is, well, that's not good, but in this case it might be very good. So, but I wonder if you can talk a bit about how you're navigating the landscape, because it seems it's changing quickly and constantly in terms of abortion law and practice. So not just you know, I think not just for the person themselves, the woman themselves, but also for suppliers and others who are part of this network or networks that seem to be kind of evolving and developing as the need grows.
Yeah, and of course, our primary concern is with the person who's using the pills, right? We want to make sure that they are safe from a legal perspective. And even though most states don't specifically prohibit self-managed abortion, there's only 2 that have laws on the books. South Carolina and Nevada have laws against self-managed abortion, and the lawyers tell us that those would probably not stand up if challenged. But even though there's just these 2 states that say you can't self-manage an abortion, we do know that people have been criminalized for that in a lot of states around the country. There have been 61 cases over a span of 20 years from 2000 to 2020, known cases of people who've been prosecuted for either self-managing their own abortion or helping somebody self-manage an abortion. So, you know, and also, you know, mirroring our justice system as a whole, that type of criminalization falls disproportionately on people of color and youth and others who are marginalized by our system. So, you know, we do worry about that. You know, it's not a huge number compared to what we know of the numbers of people who are self-managing, you know, 10,000 just in the last tens of thousands probably in the last 6 months, and, you know, hundreds of thousands of people over the number of years that people have been doing this. But, you know, if you're the one, it's going to ruin your life. And no one, you know, nobody should be criminalized for managing their own healthcare. You know, we're not criminalizing, you know, men for buying Viagra online and using it. It's stigmatized because it's abortion. But, you know, we think it's really important that people who are considering self-managed abortion just understand that there is this potential risk and then make their own assessment about what is best for them. And for some people, we do think that there might be health or financial or other risks that they face that outweigh what they perceive to be a small legal risk. But we do always recommend that people visit the Repro Legal Helpline, which is a free service that can really help somebody understand what their risk is based on who they are, where they're sitting, how far along they are in their pregnancy, that sort of thing. Now, you also asked about what about these people supplying the pills?
Right.
Yeah. There is a case of somebody that who was supplying pills out of her apartment in Brooklyn, who we listed on our website, on the Plan C website. She got a ton of business, and then she was discovered, and she was prosecuted, and somehow reached some sort of plea deal on that. But yeah, people can get in trouble for doing this. We don't pay a lot of attention to these online pharmacies and these suppliers. I mean, that's their choice that they are supplying in this way. They're eager to be listed on our website to get the business. But we are working with licensed clinicians who are trying to get shield laws set up in states. And shield law, by shield laws, I mean a specific legal protection in a liberal state that would allow a clinician to prescribe via telemedicine abortion pills into a state with restrictions. So this has happened in Massachusetts. There is a law in place that changes the location of the telemedicine service to the location of the provider. Normally, it's just designated as the location of the patient. That's how telemedicine generally works, but this law has done that. And we do have a provider that we're working with who is starting to test that shield law to write prescriptions for people in restricted states. So we're also working with a group that's trying to get this similar law passed in New York. There's a similar law in Washington that Representative Drew Hansen is putting forward. Vermont is another group we're working with. California. We're trying to get as many states as possible to pass these shield laws, and then we have providers that are waiting who are willing to do this, who really, really want to do this as a way of changing access. And if we can get these things set up, operationalized, and to stand legally, then it would be a way to get around some of these laws that are preventing access.
But the shield laws, I mean, they're protecting the provider and the user in this case, or only the provider who's prescribing from a liberal state to a more restricted state?
They are designed to protect the provider. I think that the consensus is that if a patient, if somebody is like sitting in Texas is getting a prescription from a provider in another state, they're not doing anything wrong if they take that medication in Texas. But of course, these legal issues are uncertain, right? There's a lot of uncertainty, but I think the bigger concern in that case is for the provider, their medical licensing. A lot of the providers that we're working with are close to retirement and they feel like they can take this risk, or they're recruiting other friends who are close to retirement. And some of the younger ones are really more concerned about it because it is experimental and it's hard to know how it will play out.
Right. I'm going to take another question from the chat because I think it's related to what we're talking about right now from Annika. And she says, I'm curious where you think profit-seeking companies fit into this fragmented landscape of abortion access. Companies like Hey Jane and Schwa focus almost entirely on mailing abortion pills to patients in restricted states. These companies are experiencing rapid growth and investment and drawing a greater attention to the availability of abortion pills. Do you want to speak to that?
Yeah, so we work with Hey Jane and Choice, or Schwa.
French.
Yeah, yeah. We actually, Hey Jane was one of the first companies to start thinking about this, to start thinking about a new model of care, and we provided them with some funding to get started and up and running, and we helped them define their model. We encouraged them to use an asynchronous model, one that didn't involve a video visit. So we were very involved in that. We've worked with Choice and others. They do not provide to restricted states, though. They provide only in states where there is licensing. They are and they're not making big profits, I would have to say. They are trying to provide, modern medical care in a convenient, confidential way. If you go on their websites, they're fantastic. It's very easy, very destigmatized, and we're working to hook up these telehealth services with funds so that they can, reduce the cost of the service and get greater equity. They're all working on trying to get insurance coverage for this model, and also to try and get Medicaid coverage for the model. It's a lot less expensive using a telehealth service than it is using clinic-based care. And that's not to say that, everything needs to be telehealth. We're always going to need clinics and clinic-based care as well. I think where this question really is interesting is with these online pharmacies, because we do think they are price gouging. And we know that the retail cost of the packets they're sending is like $6, and yet they, some of them charging $450 for this.
Say the online pharmacies, are these the unregulated pharmacies that you were talking about before?
Yeah, these are the unregulated pharmacies. Yeah. So there's all these telehealth services in the United States that are run by licensed clinicians, and they range in price from about $150 up to $300 or so, depending on which service it is. And then there are these unregulated pharmacies that we also list. We call them online pharmacies. There's no consultation with that. There's no follow-up. They're generic pills from India, all of that. So I think that's where some of the price gouging is happening. And one of the things we're considering is whether we say we will only list on our site pharmacies that come in under a certain pricing. And that might be one of our ways to, influence the market. So we're, in conversation about next steps in that department.
Let me shift, and we can come back, of course, to the US context, but I just want to shift a little bit more to the global picture before our formal fireside chat winds up. And so I'm wondering if you can talk a little bit about how other countries are navigating access at this point to medication abortion specifically.
Yeah, well, we do know that these pills are social marketed in a whole bunch of countries. Again, DKT, PSI, Marie Stopes, all of these have really successful social marketing programs that involve, packets of, they're called MTP kits, medical termination of pregnancy, the 5 pills together. And they're basically available over the counter. They are on pharmacy shelves. You might have to talk to a pharmacist, but you don't need a prescription for them. And then we, obviously also in some countries, those products are not available. And that's when services like Women on Web and Women Help Women would come in to try and help provide that access. But it's, there's still so many restrictions. It's still so stigmatized. Like the situation in Poland right now is just horrible for access. So, it's similar to the United States. It's, there are advances, there are opportunities, but there are also really still severe challenges to access for a lot of people.
Yeah. Well, and I guess related on sort of the global front is, again, given our audience, what do you think global health organizations and practitioners what can they learn and potentially apply from the example of Plan C in their work in other regions? How do we go about creating greater global access is really the question to the full array of reproductive health care, of course, but abortion's an important part of that. Yeah,
well, that's such a big question, first of all. But there are so many intersectionalities among global health issues. And I know you work on LGBTQ+ issues, right? And if we were to look at gender affirming care, we would see the exact same issues, right? The stigmatization, the difficulty in accessing the product, all of that. How do you let people know about it?
Moral panic, yeah.
Yeah. So there are those sorts of things. It's interesting when I think when I first started working in public health, I was totally naive, right? I was thinking, oh, well, public health is about health, but I mean, it really is about the social determinants of health, and so often, injustice in one area prevents access in another. So working on public health is really about working on justice, right? And so, I don't know if I have the answer to that question of how do we go about creating greater access to this full array of services, but I would say that some of the lessons that we've learned at Plan C that's led to our success in introducing these new models of care are be bold, be creative. We've been very nimble to take advantage of opportunities as they've arisen. We haven't necessarily believed what we have been told in terms of what's possible. I mean, people told us you can't mail pills, and we got providers to mail pills even before the FDA changed that language. I would encourage all of us to use a justice lens as we do our work, and really, maybe most importantly, center the end user.
Yeah.
So often we are driven by donors to have certain perspectives on things, population measures or, certain outcomes. And I think that any intervention, first and foremost, really needs to meet the need of the end user. Because if you're not meeting that need, that issue or topic or treatment or whatever is just never going to take off, right? So focus on the user. But I'd be interested, this is a great group, of a lot of experience. So maybe in the discussion, people have ideas as well on this.
Yeah, I mean, and I think we also have to just name the reality that there has been for many years kind of a chilling effect in terms of what donors are willing or not willing to support in this full spectrum of reproductive health. And, organizations are concerned about where they get their money and whether they'll continue to get money depending on what they're doing. And I think that unfortunately has had a chilling effect on the activities of a lot of organizations that are mainstream public health, global health organizations.
Yeah, absolutely.
Yeah. Just a couple of more thoughts and then we're going to open it up for more questions. But I think, that I'm imagining, because I certainly am, this is incredible to learn about the work of Plan C and also just the global movement around abortion access. And I'm wondering if there's anything you can suggest to people who are listening to or participating, how they can be helpful. I mean, I'm thinking, well, what can I do to be part of this movement to help increase access?
Yeah, I mean, people ask us this question all the time, what can I do? What can I do? And I would say, one of the huge things that people do is spread the word and talk about abortion, right? Yep. It's so stigmatized, people don't talk about it, but let people know that abortion is safe, it's common medical care, and that especially in the United States, that this basic medical care is being withheld from about half the people of the country, right? And it's being withheld by politicians who are really out of sync with the American public. I mean, there is no reason why someone living in the Texas zip code shouldn't have the same access to abortion care that I have in Washington State, right? It's pretty ridiculous. And, continue to advocate for fully legal, affordable access to abortion care in all states. It has to be accessed through clinics, through telehealth, and self-managed. Make it free. The New York City public health clinics just announced that they're going to make abortion free. So, could we do that? That would be huge for equity. Denounce criminalization. Criminalization, especially because it's disproportionately impacting, people who already don't have access to services and who are suffering economically and in other ways. And then support organizations who are doing this work. There's tons of organizations working on this now. Everybody's working really hard and can use your support. If you want to be a little bit subversive, and especially if you're traveling to states with restrictions, you could get some Plan C stickers off our website. Some of them say want to be pregnant, and it has our QR code that goes to our website, and people have been putting them up. We've done, I think, more than 1 million, maybe even 2 million so far of orders, and people are putting them up all over the place. We're always hearing about spottings of our little Plan C stickers. So that's the way you can be a little subversive. Put some in your wallet and
I love that.
carry them with you when you visit Arkansas.
I love that. This has been amazing. Is there anything I haven't asked you about that you want to share before we open it up for Q&A? Anything I missed or that you feel is really key for our audience to hear?
Just that we have the technology, we have modern ways of providing it to people through the mail. And the only reason for the terrible situation that we're in right now is politics. These politics are causing harm, especially to people of color and youth and people who don't have access to resources. And we do really believe that resistance in the form of sharing information and making pills available is what will inevitably lead to systems change. And we hope ultimately to over-the-counter access. So, I mean, we share a hopeful message at a time when, things are really horrible. So both of these things are existing in tandem.
Yeah. I mean, it's so important to find some optimism in this sort of bleak landscape that's gotten bleaker in recent months. But what you're doing is absolutely incredible, and the work of Plan C and all of your partners, it's so vital and so important. And thank you so much for sharing your knowledge and expertise and experience. So I think I'm going to open it up. I see we have a few questions in the chat already, and I encourage everyone to please jump in and add their questions as well. So let me start. We hit the first couple. I think Joni Robertson. Hi, Joni, a PATH colleague. I heard an interesting conversation in a podcast a few months ago that talked about rebranding abortion pills as menstrual regulation pills as a way to skirt some of the politics or make it easier for some of the population to accept the method. Do you have any thoughts on this?
Oh, absolutely. And I love that question. Thank you. As you can sort of tell from our name, Plan C, we don't call it abortion, right? The idea is Plan A is contraception, Plan B is emergency contraception used right after unprotected sex, and Plan C is something you can do when your period is late to bring your period back. It does not have to be abortion, and you're absolutely right that in many places where there are abortion restrictions, menstrual regulation has been a very effective way of offering a service that is not politically controversial. So, Bangladesh uses what's called medical menstrual regulation. They used to do it with aspiration procedure, but it is done with the pills, right? Within 2 weeks of your missed period, you don't take a pregnancy test. And I see that's another question that Vivian has put in. So you don't know. I mean, you don't know, are you pregnant? Are you not? Some people, prefer not to know. Some people might want to know and avoid an unnecessary treatment. So yeah, we think that this is absolutely important, and we're looking at it. We're also looking at things like advanced provision, which could be a way of getting pills into places that have 6-week bans. But this idea of menstrual regulation too, it would be an off-label use of mifepristone, and it could enable a provider to say, oh, well, I prescribed it as a missed period pill, not as abortion. So it could be a way of a provider to legally prescribe the pill without running afoul of abortion bans. So yeah, believe me, we are looking at all of these permutations of words and service delivery options and trying to find clinicians on the ground in restrictive states who are willing to test out these types of models to challenge the unjust laws that are out there.
I just, my own follow-up question to that is I mean, I worry though that the opposition, the anti-abortion movement is likely anticipating these moves and sort of the way that you're navigating and trying to create openings in very restricted spaces. So, I mean, do you feel like you're still sufficiently a few steps ahead of the opposition, or what's that dynamic like, and how do you anticipate what might be coming?
Yeah, we basically look for the opportunities and just keep moving with them. We anticipate that the antis are also looking for those same things. And that's why, you know, we can't rely only on policy and policy change. We've seen that. We've waited forever. I mean, we've waited for the FDA to make decisions based on science, and it still hasn't happened, right? It should have happened by now, but it hasn't. So, I mean, that's why, you know, the part of the work that we're doing with these alternate suppliers and alternate networks is so important, because that is what is providing a lot of the access in these restricted states right now. It's not policy change, and, you know, we may never see policy change. So yeah, we, you know, and we waste a lot of time trying to respond to you know, blockages that are put up by anti-choice people, and even blockages that are put up by people who aren't necessarily anti-choice, but systems that are afraid. You know, Google, Facebook ads, we get blocked all the time, and we say we're providing public health information that is, you know, critical to this public health emergency right now. We shouldn't have to be fighting, you know, with Google and Meta right now.
Especially what seems is allowed on those platforms comparatively.
If anyone has any influence there in Seattle, let us know.
Claire asks, one of the slowest quote unquote fights we combat in public health is policy change. So this is what we're talking about, and implementation. What is your vision for Plan C in the next 5 years if legislation does versus does not change? So very related to what we're talking about.
Yeah. And again, I mean, from the beginning, we have not held out much hope for policy change. I think the most exciting part of the policy change right now are these shield laws that I was talking about. And we are pretty aggressively pursuing those with providers and with state legislators. But otherwise, I think we are still trying to figure out, you know, how can we get more advanced provision to be happening? How can we work within the existing situation to really show a different way that can be done legally within that system? And how can we support, again, these alternate networks to grow, to become more sustainable, to really shore them up so that as politicians continue to fail us, we at least have other systems that are more robust than they are now.
Great. Going back to another question that came from Fatima, have you come across any situations where it was easier for cis women to receive abortion pills than I think trans men probably, or vice versa? Do you see an impact of, I guess, the sort of additional stigma and discrimination for non-heteronormative women?
Yeah, that's a great question. And we are not, you know, direct service providers, so I can't answer that from my direct experience with Plan C, but we have heard that. We have heard that from folks that that they have been discriminated against when seeking services. And interestingly, we have heard that one of the benefits of these asynchronous telehealth services is that you don't have to appear on a video. You don't have to be misgendered. You don't have to experience that. And so it's a lot more welcoming, we've heard, for trans and non-binary populations, because they don't feel the same judgment or misgendering that they might in an in-person visit.
Yeah. Great, thank you. Other questions, please send them along. We have a few more minutes. And in the meantime, let me just ask one other question. Well, I hope more will come. But in terms of I'm not asking you to share the donors that you have, but are you finding that you're better able to fund? I mean, how's your funding in this moment? Are you attracting more funding? Are you finding that you're receiving more funding? Are you feeling like there's some momentum behind this movement in a way that didn't exist before?
Absolutely. Yeah, we are in a good space now with respect to funding. We have had some generous large grants come in, and we're trying to spend money quickly because, part of it is running ads. We've been running iHeart Radio ads in Mississippi and Oklahoma and Kentucky and Arkansas. We're involved in a big campaign that we're developing in partnership with groups on the ground in some of these restricted states. What's the best messaging for people to drive them to our site so they can get more information, so that they can, have all this. So we are finding that we're getting a lot more funding now. I mean, we have individuals sending us $10, or we have a family foundation that we've never even heard of or asked for money from sending us $20,000, or it's really been amazing, the outpouring of support that we have, and the cheerleading that all of these supporters have given us. It's been really, really heartening. That has not always been the case. Initially, when we started out, it was very hard to find funding. We had donors who funded us and then they defunded us. The one example is, it was an anonymous donor fund. We kept them anonymous. We said our project was called Bold Actions in Support of Putting Abortion Pills in Women's Hands. That was the title of the project. And we said we would get publicity, that we would get in the New York Times and share this information. And when we did get in the New York Times, they called us up and they said, that's untenable. We can't support that. Anyway, they withdrew our funding. They later came back to us and they said, oh yeah, no, you're doing interesting things. So, I mean, a lot of times the donors are getting an earful from lawyers who are saying, that's illegal, but we don't believe we're doing anything illegal in doing research, sharing information, and helping develop new routes of access that we think are, finding ways around these legal barriers without breaking the law. So I think we're the ones, when Dobbs happened, that were really well positioned for the moment, right? Because of the work that we had been doing since, the 2013, 2014.
Yeah, thank goodness. Vivian has another question, and actually it's a good one. I meant to ask this myself, but could these telehealth services be used to get advanced provision?
Yes, that's a great question, Vivian. And thank you for that, because now I can talk about it. Yes, they are being used to get advanced provision. So Aid Access does advanced provision. And Choice in California does advanced provision, and they're in other states as well. Choice, I don't know all the states they're in. Also Forward Midwifery is doing advanced provision, and a couple of the others. And we actually added a special little indicator in our guide to finding pills on each of the search results that indicates whether the providers do advanced provision. And I would encourage all of you to go to our website, plancpills.org. And you'll see a little button that says Get Pills. And I encourage you to click on it and put in Washington State, or whichever state you're sitting in, and see what options are available. And then put in Alabama or Texas and see what the options are that are available. California is one of the states that has just tons and tons of options. So that would be another good one to look at. But Washington also has a lot of options now too. Just so you can see this disparity in access, and to see how easy it is to get abortion care in some places, and how absolutely difficult it is with risk of criminalization. And without all the normal funding mechanisms for these alternate routes of access that exist, maybe if you're going to a clinic or through a more standardized route of care.
Mm-hmm. Great. I'm like turning, I see Claire has a comment and then one more question. That's probably, we might be able to take one more after this, but we might run out of time. Claire just notes that it's actually interesting to hear a perspective where policy change is not the main goal, or there are low expectations towards it, because there has been that has been the center of so many global health programs. This is a great conversation and bringing a lot of new perspectives to how I think about my work. And I think that's true. I think, we're all conditioned in a way to think that policy change, I mean, it is critical at some point, but sometimes the need precedes the ability to change the policy. And I think it's just a tremendous example, your work of how sometimes you do, in a way, need to move things forward, even in the absence of clear policy.
Yeah.
Comment on that further.
Yeah, thanks, Claire, for that observation. I mean, you're absolutely right. And we do, I don't want to say that we don't need policy change. Obviously, we need huge policy change. It's just that it's so discouraging to wait around for it, right? Because we've been waiting for however many years. And even though we had the change, in 1973 with Roe, now that's gone, right? So it's not a guarantee. So yeah, I think, our dismay at the lack of reasonable policy on this in the United States led us to our approach of just, creating these routes of access. And now it really is, I think, in part, this systems change that's going to drive policy to catch up. Certainly that we were told that by the one of the distributors of mifepristone, that one of the reasons that this FDA decision came down saying that, yes, you can mail the pills and they can be stocked by a pharmacy, is because of the work that we did during the pandemic to get those systems up and running and to demonstrate them and to then have data that would support that. I remember in the summer of 2021, I was on a movement call. The lawyers were talking, and they said, and I thought I heard them say that, that providers could contract with a contract pharmacy in order to dispense these medications. And I couldn't believe it. I was like, wait, did I hear that? That just went by and now they're not talking about that. So I quick emailed the person who was speaking and I said, did I hear you correctly? And she said, yeah, they can now contract with these pharmacies. Well, lo and behold, we were in conversation with a pharmacy saying, we're going to try and figure out how we can get you to mail order these pills, to be the ones dispensing it. So I said, we've got the pharmacy, and we got them set up. And in fact, they were the first one in the US to do it. The other distributor, one of the distributors, was really interested in working with us on that. And, we were able to get this group set up within a week or two. We talked to the other distributor and said, you want to do this? And they were like, well, let's wait. That's going to change. That's not going to hold. That's not going to stick. And we're like, okay, we're not working with you. We're going to work on getting it up and running. And we said, we don't care if it's turned over, turned down, whatever in a month. At least at that point, that pharmacy will have standing to challenge that then.
Right.
So yeah,
Great.
No moss growing here.
No. All right, last question. I know Plan C is focused on the US experience, but how does what is happening here relate to what is happening in other countries? Just as you said that the concept for this came from women in Brazil and other countries, is what we are doing here important and relevant for similar groups in other countries? And are you learning from other groups, or is the US just an outlier at this point?
Yeah, no, I don't think the US is an outlier. I think that everybody is learning from each other. Yeah, there's just lots of cross learning. I know that the UK has set up, when the pandemic hit, they set up telehealth abortion. They call it pills by post. Pretty much overnight, they set it up really quickly. There's a lot of learning from those data. Again, Women Help Women and Women on Web are demonstrating models. We're helping inform those models from what we're learning. So lots of cross learning. And again, I think there's more work being done in other countries on later term self-managed abortion. I know Indonesia and some of the other countries with severe restrictions are doing a lot of work in that area that we can learn from. And a lot of apps and ways of sharing information with people. We're in contact with different groups internationally, I think is more advanced than we are. So there, again, we're learning from them rather than sharing information. But yeah, lots going on, and mutual support to help advance the cause.
Great. We have to end, but I do want to give you the opportunity. I'm not sure people realize that Elisa is going to be a movie star. No, just quickly, can you share, there's been a documentary made about the Plan C effort, and it's going to the Sundance Film Festival and then perhaps wider release, is that right?
Yeah, this has been a sort of interesting part of our work, is that over the past 4+ years, we have been followed by Tracy Dross Tragos, who is a documentary filmmaker. She's done another film about abortion. And she has come to some of our team meetings and followed us around and interviewed us and watched what's been happening with our work and the movement. And she put together a documentary that is actually called Plan C. It's not necessarily about us as an organization, but it's about some of the things that we've put into motion. The main character is Francine Coiteau, Plan C co-founder, co-director, and it is premiering next Monday at Sundance. And Tracy, the filmmaker, is hoping to sell it because she's invested a whole lot of money in it. And so who knows where it's going to be available. It's not available online yet, but hopefully at some point, maybe Netflix or something, you will be able to see this story of the abortion underground, I think is sort of the framing of the movie.
Yeah, great. Elisa, I really can't thank you enough. This has been incredible. Your work is so vital. As I said earlier, I wish I could hug you and be in the same room, but thank you so much. And I'm gonna hand it back over to our hosts. But wow.
Well, and thank you, and thanks to everyone in the audience for your great questions. And I'm always available to talk more about the work or answer questions if people have emails or whatever. So thank you so much.
Thank you. Thank you, Amie and Elisa, for co-hosting such an informative session. And thank you to everyone for engaging in the conversation today through your insightful questions, your attention, your comments in the chat. We really enjoy these quarterly gatherings. And we also want to make sure that you know that there are more ways to stay connected with us. So for those who are interested in future WGH events like this one, please do subscribe to our mailing list. You can also connect with us via the LinkedIn page, follow our YouTube channel, and we also welcome you to sign up for small groups if you're interested. A few of the current groups may have openings, but if not, small groups run by the calendar year, closing in December and restarting in the new year. So that means that we have quite a few groups that have started up again. And to follow along with WGH Global, so this is the Seattle chapter, but we're also connected with Global. Please feel free to follow their Facebook page, and lastly, save the date for our next quarterly gathering, which is going to be on Thursday, March 9th. And we will be sending out emails for those. And that concludes our formal programming for today's event. Thank you all so much for joining us.